And my basic intent is to talk about very common cancers, which all of us deal with across the globe, the commonest cancers across the globe. And the way I want to do it is just have a case-based discussion in which we will want to, I am okay to have your inputs in chat or live, whoever wants to ask, because the whole purpose is not to miss any case who's diagnosed with cancer at the right time. When you diagnose cancer at the right time and they are treated well, then there is a significant chance of cure. As the word goes, if you have treated them correctly, more than 50% of all cancers are curable, and 100% of all cancers can actually receive treatment which serves them good, either to increase longevity or cause symptom control and provide good quality of life. So, the way we function in my center, we have a comprehensive cancer center. And the way we function is multidisciplinary tumor board, in which every patient meets a set of oncologists, that is medical oncologist, surgical oncologist, radiation oncologist, and oncopathologist and oncoradiologist. All of us discuss about cases and then come to plan whether patient requires surgery, chemotherapy, or radiation therapy, and in what sequence. So this is my team, and these are all senior, well-qualified consultants who have studied in India and abroad. So we'll start with one basic scenario. I think the most common cancer across the globe in women. And this is a 35-year-old woman who's married and who has been trying to conceive. But she has regular periods. And at this point in time, she has been visiting fertility specialists to find out why she has not been able to conceive. She's a software engineer by profession. I work in south of India in a place called Bangalore. And this Bangalore is known as Silicon Valley of India, where we only have software engineers and computer engineers. So anybody who will come to us, we would definitely assume that they are software engineer. So when she came to us, she presented with a painless lump in the right side of breast. This breast lump was increasing in size. It was increasing over the past 2 months. And when detailed history was taken, there was a family history of breast cancer in mother, and her aunt had ovarian cancer. And both of them had cancer at a young age. Both of them were premenopausal when they were diagnosed. Mother was 45 years of age, and aunt was again 47 years of age when she was diagnosed. So when she came to us, we first did a clinical examination, which showed a right breast mass. This right breast mass was about 4 into 3 centimeter. It was hard and irregular, and it was in the upper outer quadrant of the right breast. Along with it, there was a right axillary lymph node, which was 1.5 centimeter. So what would we have done? Now remember that this is a young woman, 35 years of age, and who comes with a breast mass. So we have to remember that in a young woman, generally in their 20s, cancer is not the first thing in our mind. But here it's a very unique situation because clinical examination suggests a hard, irregular mass. And on top of it, she has mother and her aunt who had cancer in the family. One had breast cancer and one had ovarian cancer. So when you examine, when a patient comes to you, we do triple examination. Do a clinical examination, note the clinical characteristic. Secondly, at least ask for an imaging, which could be an ultrasound or it could be a mammogram. For a 40 and above woman, we will do a mammogram. But for a woman less than 40, we would like to do an ultrasound of the abdomen. And if there's anything suspicious, we do the third thing, that is a true cut biopsy, not a fine needle test, but a true cut biopsy. So this is what was offered to her. And in the meantime, her baseline investigations were done and her blood work was normal. And a beta HCG was done to rule out pregnancy because there are quite a few investigations which cannot be done if the woman is pregnant. So an ultrasound was done which showed a BIRAT 4 lesion. In this case, a mammogram generally should be offered over 40, but if there is high suspicion, we may occasionally want to do mammogram. And there was a speculated mass with microcalcification. A biopsy of this was offered, and this biopsy came out to be carcinoma, which was subtype as invasive ductal carcinoma, grade 2. And then once we have a biopsy, we always make sure that we find out the subtype of breast cancer. So in this, estrogen receptor, progesterone receptor, and a HER2 receptor was done, and all the three were negative. So it's known as triple negative breast cancer, which is a very unique variant in young women and also the most aggressive type of breast cancer. So if you have a young woman with triple negative breast cancer, consequently, it's a very aggressive cancer and it is a systemic disease and requires very urgent management and very aggressive management. So what is the plan? Well, unlike what we all will assume, the first step is not surgery. So patient underwent a PET CT because in India, PET CT access is easy. Cost works out very well. Instead of doing CT chest, CT abdomen, pelvis, and a bone scan, a comprehensive PET scan is often done. In every city, there are several actually scans which provide reports in the next few hours. There are various type of PET CTs. One requires fasting, and there are scans now which don't even require fasting. All we require is to check kidney function so that iodinated contrast can be safely administered. So a PET scan was done, which showed it is a not metastatic cancer. And first thing is since she's 35 and this is a curable cancer, so fertility discussion is the norm. You will have to make sure that you have spoken to the woman how to preserve her fertility for future because that has been her goal. So fertility preservation option in a married woman is often embryo cryopreservation, and an unmarried woman could be oocyte harvesting or ovarian tissue cryopreservation. Since she's triple negative breast cancer, she was offered a neoadjuvant chemotherapy and followed with surgery was offered. Now, again, she had a very strong family history. So, a genetic test was offered, which is actually a blood test. And that blood test actually showed that she had a very strong mutation, which makes her at a high risk of familial cancer, which means it could be bilateral and it could also show up in other places like ovaries or pancreas, or in men, if you have that mutation, it could be in prostate cancer as well. So let me summarize with a breast cancer patient. We will always do a self breast examination from 18 years of age once a month to all women. That is one thing which we have to talk amongst our family, amongst our friends, amongst our neighbors, and amongst our work colleagues. Once a month, self breast examination. Please note if there's any lump and get it checked. From 30 years of age, every 6 months, a clinical breast examination by a trained specialist. That trained specialist could be an oncologist or it could be a gynecologist. However, the treatment is often offered only by an oncologist. Starting from 40 years of age, a once a year mammogram is done. So these are the screening guidelines. Remember?
Dr. Niti, can I disturb you for a minute? So
Yeah,
what
Varun.
this examination, the screening examination should be done by a gynecologist or an oncologist. Can a general practitioner do it?
See, Varun, self-examination should be done by everybody themselves. There are short videos which you can see on YouTube and learn how to do self-examination of the breast, of the underarm, and the neck area. So we take opposite hand and opposite breast, and with the flat of your hand, with 3 fingers, flat of your hand, we should do self-breast examination, and examination of the axilla, and examination of the neck. Clinical breast examination is always done by trained people. Now, in our country, the mandate is we train everybody, whether it is nurse practitioners, whether it's physician assistants, whether it's internal medicine doctor, whether it's general surgeon, whether it's gynecologist, whether it's oncologist. So, clinical breast examination is done by everybody who are trained. So, we have to find out a kind of spectrum where actually people have been treated for cancer, because missing these lesions is very often the case. So, it should be a trained person who's doing it. And not just that, if there's any doubt, an ultrasound should be done immediately. If there is any doubt, and more than 40, a screening mammogram is recommended.
Okay. Thanks, Dr. Niti. My question was, can a GP also do it? So as you said, that every trained medical
Yeah.
professional,
Training is required, then yes, they can do it.
any medical
Absolutely.
professional who has been trained can do it. Okay, thanks.
Or Varun, the basic thing is that as oncologists, we should tell everybody to do it. Any woman who comes to your clinic, you should offer a breast examination. Now, if a male doctor is there and they would prefer their nurse doing it, but general dictum is that breast examination should be done in the clinic for any woman who comes to the hospital.
Thank
So
you.
I would suggest that all GPs, all general practitioners, internal medicine doctors should see how to do it and do it for all the women. Next thing is, this is standard risk screening. The second thing is high risk screening. Now, high risk population is the population which has been proven to have genetic mutations, which I suggested. So, if you have a strong family history, you have to go to your oncologist. You have to make sure that you discuss your family history and your doctor or your personal history, because you may have had a cancer in the past and you have another cancer. So you have to discuss your personal history, family history, your addictions, and then the doctor tells you whether you fall in high risk category, where certain other tests are recommended, like an MRI of the breast, or there'll be tests like, if there's a strong suspicion, they may ask for a blood test to check whether you have mutations. Now, moving on to the second case. Now, this is a 52-year-old male. I'm sure in your country and in my country, this is again a very, very common scenario. He actually was a farmer by profession, and his presentation was persistent cough with weight loss. It was a 2-month history. He also had intermittent low-grade fever. And when he would cough, he had couple of episodes in which he brought out blood, which is hemoptysis. There was no chest pain and there was no breathlessness. So, can anybody tell me what would they do next in this patient?
Anybody, Dr. Innocent?
Anybody, please message or just please join in. Matlab, whatever you are comfortable. Would you do an X-ray in this patient? So,
Sorry, I'll do a gene expert for tuberculosis for acid bacilli.
yeah, perfect, perfect. Yes. So actually, the patient underwent a chest X-ray. We have a very similar scenario. So I appreciate that you said that you will do a gene expert for AFP. So a patient underwent a chest X-ray, and this was the X-ray finding. As you can see, there is a lesion in the left apical uh, lung lobe, upper lobe of left lung. There is inhomogeneous opacity, and actually, patient underwent a gene expert which was negative. But patient had weight loss, hemoptysis as the presentation, and occasional fever. So patient was put on an anti-tubercular. Now, this anti-tubercular was 4-drug ATT, which is the current norm here, along with the paradoxin. And at 2 months, his symptoms did not improve. He had very similar problem. He had still hemoptysis and he still had cough. And then the patient was referred to us. At that time, taking a detailed history, we also found out that he's a chronic smoker of 25 years duration. He has been smoking for a very long time, and you would smoke almost 20 cigarettes per day. And we asked for a CT of the thorax. And this CT thorax showed a spiculated mass in the left upper lobe of lung, which was 3.5 centimeter. And there was no pleural effusion. This lesion was very close to the left main pulmonary artery. Possibly that could be the cause he was having bleeding. And as I said, no response with 20 pack year of history. AFB on smear, the sputum smear was negative. Gene expert for acid fast bacilli was negative. And even the TB culture was negative, which was sent in the first time. And this was again repeated. This was negative. So what we did a PET CT scan, which is a positron emission tomography. And in this, the PET CT is a functional scan plus an anatomical scan. So you have an image on the CT scan, and plus you have activity on the PET scan. So as you can see, there is a lesion in the left upper lobe of the lung. And also there are mediastinal lymph nodes. As you can see in the lower down picture, the lit up uh, mediastinal activity, orange one on both the side. This was the mediastinal lymph node. And this was the primary lesion in the left upper lobe of lung. Now for us, the basic intent when we see a scan like this is whether we can biopsy from a suitable site. Whether it's tuberculosis or it's malignancy, the final dictum is getting a good tissue. So we would want to find out if the lesion is central or it is peripheral. So if it's very close to the bronchus, you would possibly do a bronchoscopy and bronchoscopic guided biopsy. But if the lesion is very close to the chest wall, then we can do a CT chest and a CT guided biopsy. So this is the first image in which any lesion which is very close to the, like here, it is very close to the mediastinum, the lymph node can actually be seen on an E-bus, that is endoscopic bronchoscopic ultrasound. And when you see a lesion, we can actually put a needle and do an FNAC, transbronchial needle aspiration, or a transbronchial biopsy can be done. And at the same time, a CT guided lung biopsy can be done for the left upper lobe of lung. Now, why both are important in this particular case? Because we also have to stage the disease correctly. So on the biopsy, this was lung cancer. And interestingly, it was T2N2 disease because mediastinal biopsy was also positive. And when we have a patient like this, especially of South Asian ethnicity, we make sure a molecular test is offered because 50% of such patients, actually up to 60%, may have molecular expression of some marker. It could be EGFR, it could be ALK or ROS. And if it is positive, only tablets can be given for treating lung cancer. You understand the value. So it's very important to offer molecular testing, and therefore tissue is mandate. But now we sometimes often do blood test, which is known as liquid biopsy. Liquid is like blood, and we can get more information from blood as well. So it's known as liquid biopsy, where we get information like EGFR and ALK, and we give suitable tablets. So here the role was to establish TB versus malignancy, and the plan was chemo radiation in this patient. And molecular testing is absolutely mandatory for all adenocarcinoma, but also for squamous cell carcinoma. So what are the red flags here? And I think this is what I want to emphasize. There's a speculated mass, there's persistent symptoms, there's no response to antitubercular drugs, and there's a PET scan which is showing avidity. These all put together are strong red flag indicators of malignancy. And what we need to do is establish a diagnosis by doing a biopsy. Also, let me quickly talk about the screening guidelines, especially in our countries. These are actually extrapolated from US Task Force, which says that if you have any patient who has 20 pack years of smoking history and who have been taking in the past 15 years as well, they should be offered once a year CT of the chest, which is a low dose CT scan between 50 and 80 years of age to rule out if there's any lung lesion which requires to be evaluated. Now, this is again a very interesting scenario, especially for us. A very young gentleman, 37-year-old, who came to our hospital. Actually, currently patient is on follow-up. All the cases I mentioned are routine cases. So this 37-year-old actually went to the GP, his general practitioner, whom he said that he's always getting tired. And recently he has had some abdominal pain, more on the right side. And that's about it. And then when the doctor prodded on the history, he found out this his aunt and his father had colon cancer. And another aunt had uterine cancer. This was the history. And since the GP was very smart and he knew that there is something which is not right in the history, he was suspicious, but he asked for some basic investigation. and he found out the hemoglobin was 9. Now, for a young male, a 35-year-old, 37-year-old male, hemoglobin 9 is red flag, because for a young woman, 37-year-old woman, you can actually say a reproductive age group woman will be anemic. But a male, young male being anemic is a red flag. And he also mentioned abdominal pain. So, first, a stool for occult blood, a hidden blood was done, and it was positive. So, the GP knew that the patient is bleeding from somewhere, either from the stomach or from small or large intestine. So, can you all tell me what would you do next? Would you do that? What would be your preferred next investigation?
Dr. Ibimia? Anybody? What should be done here?
So,
Endoscopy.
yes, sir.
Colonoscopy. It's from Dr. Stephen Kope. He's from Cameroon. He's a general surgeon. So he's assisting colonoscopy.
Very nice. So, you rightly said, sir. So, we did an ultrasound abdomen pelvis. There was a suspicious dilated bowel loop. And then, since there was actually occult blood, we asked for an endoscopy, which was normal, and a colonoscopy, which is here. So, this was the colonoscopy, and in which there was a growth, ulcerative growth in the ascending colon. And as you can see, the lesion was bleeding. The biopsy was taken from this, and the biopsy confirmed it is adenocarcinoma. So once you have a patient who has confirmed malignancy, the next step is to find out more information on the biopsy specimen. And second thing is to check the scan for staging. So to get more information on the biopsy, an IHC was done. And interestingly, it showed the patient had Lynch syndrome. Lynch syndrome we test by doing a test known as immunohistochemistry, which tells us whether the patient has MSI high. If the patient has MSI high, it points towards a familial cancer. There are certain criteria when you should check. And one of the criteria is several members in the same side of the family having a similar pattern of cancer. So it could be colon cancer, it could be uterus cancer, ovarian cancer, or gastric cancer. So these cancers in one side of the family would warrant you to test for Lynch syndrome. So this patient actually had Lynch syndrome, and a PET scan was done which showed a large mass in the colon. And finally, patient was offered surgery. And interestingly, surgery showed a very localized disease. And the patient did not require anything more than surgery. So no chemotherapy was offered, because a patient who has family history and whose MSI high tend to do extremely well. And most of these patients are cured. But what we should never forget to do is to offer family counseling. The brother, sister, parents, and kids should be offered testing as well, because they could be positive too for Lynch syndrome. So for this patient, actually, the brother was tested positive as well. And he underwent a screening colonoscopy, and he is doing quite fine. No further treatment was done. So family testing is known as cascade testing, which was done, and patient was not offered any adjuvant treatment. But if similarly the patient had advanced disease, we would have given immunotherapy. And these are some of the colon screening recommendation which you and I, everybody should know. Starting from 45 years of age, once a year, stool test should be done to look for hidden blood. Extremely cheap test and extremely vital and useful test. So once a year, stool testing to see whether there is any hidden blood. It's known as fecal occult blood test. And if you belong to countries in which screening colonoscopy is a guideline, then 45 years onwards, we do 1 in 10 years colonoscopy, or 1 in 5 years sigmoidoscopy. Now, this is the next case. Again, all of them are something which at least we see very often. And the internal medicine doctors or the GPs who refer to us these are the patients who are brought to their notice as well. So this lady actually went to a gynecologist. She's a 63-year-old woman who's para 3 with life 3, and she had menopause at 52. She did not have any family history of cancer, well-controlled hypertension, and her basic complaint was there was distension of abdomen, for the past 1 month, and she could not eat too much because she used to feel very full. So there was early satiety, and she had a dragging pelvic pain. She used to feel very heavy in the pelvis when she would walk, and on lying down, she was breathless. So, would anybody tell me what should I do next? Dr. Emmanuel, I love your answers, by the way. Yes.
Yeah.
So, thanks so much. We would, what
So the
test would you recommend?
CA125 testing,
Yeah,
abdominal CT, pelvic scan, and CA125 testing.
perfect, perfect. I love the answers. At least there's some interaction. So, we just did an ultrasound because the patient was in a nearby place, and they did an ultrasound and a transvaginal scan. Absolutely, Dr. Iman. So, patient had a transvaginal ultrasound and a CA125. And the transvaginal ultrasound, I will show you the findings. So this was a transvaginal ultrasound which showed a left adnexal mass. This was 10 centimeter. It was solid and cystic with internal septations. There were internal septations and papillary projections in that mass. And there was, of course, mild ascites, a moderate ascites, because actually patient could clinically palpable ascites. So this was the finding. And then the CA125 was high. So it was 745. And as everybody rightly said, there was the red flag of ovarian cancer plus an ultrasound finding which suggested ovarian cancer. So what would we do? Would we try to actually biopsy this lesion? So what we did is further we got a CT scan done. And the CT scan showed that, sorry, and the CT scan again showed the same finding. There was a large left ovarian mass, but it also had ovarian, peritoneal deposits. There were large deposits to the extent there were omental deposits and omental caking. So there was actually areas where there were caked omentum, and the CT thorax was normal. So the patient had a suspicion of ovarian cancer, but remember that if there's only ovarian mass, never put needle to biopsy the ovary. Never. What you can do is ask for a guided biopsy from the omentum or the peritoneum. So patient here was offered biopsy from the omental mass, omental caking, and that was suggestive of high-grade serous carcinoma. But because patient had so much of peritoneal deposit, surgery upfront was difficult, and so chemotherapy was started, and subsequently CRS or cytoreductive surgery along with HIPAC was offered. So this is the quick summary of all of what all of you said. If I'm suspecting a malignant lesion, it's often in a postmenopausal woman. There's a rapidly growing mass, which is often more than 8 centimeter. It could be single, unilateral, or bilateral. The lesion will be irregular, solid, or complex, which means solid or cystic. It could have thick wall and could be irregular. Papillary projections are very characteristic of ovarian cancer, especially in serous carcinoma. Ascites is commonly associated. There's increased vascularity noted. CA125 is often associated, although we also do CEA to rule out any second Krukenberg's tumor. And the symptoms are very mild. It's known as a silent killer because they hardly have any symptoms. And often the histology is high grade serous. How do you screen ovarian cancer? Well, at this point in time, there's no screening recommendation for ovarian cancer. But if there's very strong family history, a transvaginal ultrasound along with a CA125 is recommended. Second thing is uterine cancer or endometrial cancer is also a very important emerging problem in which only endometrial thickness is the criteria. You just have to check the endometrial thickness in a postmenopausal woman. If the patient has vaginal bleeding, then anything 5 and above 5 millimeter of endometrial thickness is considered as significant. If a patient is on tamoxifen, 5 millimeter or more of endometrial thickness is considered as significant, and you need an endometrial biopsy. And if there's no vaginal bleeding history, then up to 8 millimeter of endometrial thickness is fine. So the next case is a 52-year-old lady again. She's postmenopausal and she has vaginal bleeding of 3 months duration. The bleeding is irregular and actually irregular bleeding, but whenever she bleeds, there's significant bleed. Also, there's a foul smelling vaginal discharge and there's 1 month of pelvic pain. And her obstetric history looks quite okay. She had full-term deliveries. And last baby was born actually 20 years back. There's no oral contraceptive history. And she has not been doing regular screening. Yes, Dr. Emmanuel, spot on. So on examination, well, they came to us and the abdominal examination was perfectly fine. We did a per speculum examination and that showed a friable growth in the cervix and that growth bled on touch. So there was quite a few soakage of the gauze which we used. The cervix was hard and indurated and the parametrium also was indurated. Parametrium often we see on PR examination. Yes, Dr. Ivan, absolutely. So while doing an examination, we actually biopsied the cervix. And the cervical biopsy was a punch biopsy. And that punch biopsy came out to be squamous cell carcinoma. Again, a very common cancer in your part of the globe and my part of the globe. The patient had low hemoglobin because she was bleeding so much, but her other tests were normal and the kidneys were okay. There was no hydrouretronephrosis and the renal functions were fine. So when you look at the MRI, there was lesion in the cervix extending to the upper vagina. Parametrium was involved. So it was stage 2B and rectum and bladder was not involved. And the diagnosis of carcinoma of the cervix, stage 2B, was made. And how do we treat this patient? Well, the standard recommendation of managing this patient is concurrent chemoradiation, in which five weeks of radiation is given along with weekly chemotherapy. And once this is over, we give after a week intracavitary radiotherapy is known as vaginal brachytherapy is given. And that's all. And that is it has a very good cure rates. Identifying this disease on time is the key. It seems to be associated with either poor personal hygiene, sometimes multiple partners, and of course with human papilloma virus. And therefore the use of giving HPV vaccine or human papilloma virus vaccine. Now, do you know what all cancers are caused by human papilloma virus? Dr. Ucha, Dr. Emmanuel, Dr. Ivan. There's Dr. Innocent, Dr. Stefan.
Yes, doctor. And Dr. Innocent has shared a case also that he wants to discuss with you. I was
Wow. Okay. Sure. Perfect.
we'll cover that once the
So,
case.
Dr. Emmanuel, less likely nasopharyngeal cancer, but yes, there are other type of head and neck cancers which are also caused by HPV. But human papillomavirus most commonly associated with cervix cancer. And since human papillomavirus is a viral infection, preventing this infection can cause cervical cancer. Second thing is, not just that, it can cause, very true, sir. It can cause, yes, Dr. Emmanuel, it can cause vulval cancer, it can cause vaginal cancer and cervix in a woman. In a male, it can cause penile cancer. And in both the genders, it can cause anal cancer. And then it can cause head and neck cancer as well, including oropharyngeal cancer. And then, of course, there's some association with lung and all. And therefore, it's extremely important to find out what is the strategy to prevent it. And we all should, actually, it should be ingrained in our heads that it's a preventable cancer. And any patient we meet, we should talk about screening. What do we have to do? Well, for a woman starting from 21 years of age till 29 years of age, every 3 years, she should do a pap smear. Starting from 30 years of age, pap smear plus HPV testing is recommended. That is 1 in 5 years. And this all is done till 65 years of age. So 21 to 65 is the screening recommendation for cervix cancer. And all of us should be strongly advocating vaccination. And HPV vaccination prevents cervix cancer, vaginal cancer, vulval cancer, penile cancer, anal cancer, head and neck cancers. And why? Who requires it? All kids, girls or boys, starting from 9 years of age till 14 years. This is WHO recommendation, World Health Organization recommendation. 2 doses from 9 to 14 years of age, given 6 months apart, is the recommendation. Starting from 15 to 45, 3 doses, 0, 2, and 6 is recommended. There are multiple type of vaccination. There are 2-valent, there is 4-valent, and then there is 9-valent. 9-valent vaccination is known as nonavalent, which is expensive. Quadrivalent is the most commonly used. Quadrivalent is good. And now India has indigenously devised vaccination as well, which has brought down the cost. And then, of course, two are the most important strains, 16 and 18, which bivalent vaccine also can be given. So HPV vaccination, all of you should know about, and you should give to every of your patient, starting from 9 to 14, 2 doses, 15 to 45, 3 doses. And in spite of giving the vaccination, you still have to do screening. So you can't say that, well, I will not do screening for the woman who actually has undergone vaccination. Remember that. The next is this scenario. So I didn't understand the question. What are the paraclinic explorations for extension in this case?
Dr. Stephen, if you can tell us, if you can just explain more so that we understand the question.
So because parametrial extension was there, so we always include that area while we give.
Okay,
Yeah, we always include that area to treat. And that's the reason, that's the importance of giving chemo plus radiation. And in certain cases of locally advanced, like her, we would give immunotherapy as well. I'm assuming that is what the question is.
Oh, you know, every day, me, I need a job every day here.
Dr. Stephen, can you unmute yourself and like ask Dr. Niti directly because I think we still have confusion whether we have understood your question or not.
No problem. I think we can take it later.
Can I explain my question?
Yes, Doctor.
Please.
Yes,
Yes,
I'm speaking about the precedent case.
yes,
What
sir.
was your paraclinic exploration before starting management of this case of cervical cancer?
So, Dr. Stefan, what I understand is what would we do? So, what happens is first we diagnose the case, then we do a staging scan. And in our country,
Okay.
staging scan often will be a PET scan, which will tell us the extent, whether it is in the bladder, in the rectum, or it is in the parametrium, whether the lymph nodes are involved or not. So the staging should confirm what is the exact stage. And then we see if the patient is fit for taking chemotherapy. So for assessing fitness, we do kidney function test. And that is known as a GFR studies. It's a functional kidney scan. We do audiometry to check whether the ear functions are good. And then we give weekly chemotherapy along with radiation. Radiation sometimes can cause temporary issues. So those are also informed at the same time. So first is diagnosis with a biopsy, staging scan, pre-chemo workup in which we see whether whatever treatment is given should be safe for the patient, and then we deliver the treatment.
MRI is not better than CT scan? Between MRI or CT scan, what is the you
So
think?
Yeah, Dr. Stefan, MRI of the pelvis is a very good modality. But MRI of the pelvis, we will require MRI abdomen pelvis with contrast and a CT chest with contrast, or we can do CT chest and CT abdomen pelvis with contrast. This is the recommendation. Pelvic structures are very well seen on an MRI, but at the same time, we also need to explore the upper abdomen. So sometimes we often do a CT thorax, CT abdomen pelvis with contrast or if the patient has any confusion, then we'll do an MRI abdomen pelvis and a CT thorax with contrast, because chest is always better seen on a CT scan and pelvis will be better seen in an MRI. I hope I answered your question, Dr. Stefan. I'll probably go to the next
Yeah,
topic.
Dr. Niti, there was a question from Dr. Innocent about breast cancer. He wants to discuss patient case. Should we take it up now or one?
I'll just finish it, then we
Okay.
will. Or maybe let me, because I read the question. He asked something about filgrastim. I can answer it now. So he has written, I am seeing a third stage breast cancer patient and patient currently is undergoing filgrastim injection, 300 mics for 3 days. What other plan would you initiate and treat the patient? So, Dr. Innocent, I don't know what is the treatment plan going on, but how it happens is that the treatment depends on ER/PR status, estrogen receptor, progesterone receptor, HER2 receptor, whether the patient has undergoing systemic therapy or chemotherapy first, followed by surgery, or surgery followed by chemotherapy. Filgrastim is just a supportive care injection. It's not the main injection. Filgrastim is given only to prevent drop of counts. So if a patient actually has had first time drop of counts, like the WBC counts have dropped down, this is a WBC growth factor. So as a secondary prophylaxis, we give WBC growth factor, that is filgrastim, so that the next time it does not happen. So based on what protocol we are using, the use of filgrastim will be different, but the treatment protocol this is just a supportive medication. The primary treatment will be very different.
Dr. Innocent, if you want, you can share the current treatment protocol she's on. I mean, if you want more clarity from Dr. Niti. Dr. Niti, meanwhile, we can move with the presentation.
Yeah. And I would request everybody else also to actually comment. You can please write on the chat box. It's not necessary. If you don't want to speak up, please write on the chat box. So this is the sixth case. He's a 60-year-old male, very common in, again, Africa and India. So he actually has history of jaundice 2 years back, and he has past history of liver decompensation when he had ascites and portal hypertension. He's already taking beta blockers for portal hypertension, and now he came to gastroenterologist with worsening jaundice. This was the basic background. When the patient came to the gastroenterologist offered an ultrasound. And when they did an ultrasound, they found multiple hypoechoic lesions in the liver with a background of chronic liver disease. So there was a cirrhotic liver. And then on top of it, the patient had hypoechoic lesion. This was known in the past that patient had hepatitis B surface antigen positive. So patient was a known case of chronic hepatitis B and actually was also taking treatment for that. Yes, Dr. Ivan, spot on. The patient has hepatocellular carcinoma. So now what will we do? What is our next step? What would you think we should do? So patient came to our clinic and we ordered a triple phase CT scan of the abdomen and pelvis. Triple phase actually are technically 4 phase. First is the pre-contrast phase, then is the arterial phase, then is the washout phase, and then there is a venous phase. So these are the 3 phase in which there's no contrast. So you take a plain scan. Then you give an arterial contrast, which has hyper enhancement where there is tumor. There is a washout phase where the contrast is just going off. And in that a time, there is isodense or hypodense lesions if it is liver cell carcinoma. And then there's a delayed venous phase. And the delayed venous phase actually gives the mosaic pattern, which you see in the last slide. And this actually tells us what is the Lyrad score. LIRAD means liver radiology assessment score. And if it is LIRAD 5, it is highly suspicious of liver cancer. Always remember, we need a triple phase CT scan of the abdomen pelvis to diagnose. So there should be radiological characteristic, and secondly, there should be an alpha fetoprotein which is more than 400. If you have both these things, then a biopsy is not required. Only criteria is that triple phase CT scan confirms liver cancer and the alpha fetoprotein is more than 400, especially in this patient where there's a background of uh, the patient already has a hepatitis B surface marker.
The leaving my charger.
Yeah, hi, Dr. Olyanka. Hello, Dr. Olyanka.
Yeah.
Please go ahead, ask a question. Dr. Niti, Dr. Olyanka was recently in, he trained,
Possibly. It's possible.
he trained in Gangaram. He did his training in Gangaram Hospital under Dr. Nandi in gastroenterology. Yeah, Dr. Olyanka, yeah, please go ahead, ask a question. Hello? Okay, ma'am, let's proceed ahead.
Yeah. So basically a triple phase CT scan or quadruple phase CT scan showed that the patient had a hyperenhancing lesion. And of course, there was typical features with LIRAD 5 scoring reported. The alpha fetoprotein was 540. So in this patient, biopsy was not required. HPV DNA was done. The viral load was done, which was high. And so antivirals were initiated. He came with history of jaundice. So his liver function were deranged. PT-INR was also done, which is a part of liver function. And it was deranged because there are synthetic functions of the liver, which was also deranged. And a Child-Pugh score of B was given. So this patient actually had a bad liver hepatocellular carcinoma. A staging scan was done, it was not spread to the chest and it was not spread to the bones. And so the patient was treated further. So, Dr. Sunday, I will address your question. So what are the red flag signs? There's a backdrop of chronic liver disease. This chronic liver disease could be hepatitis B, C, even an alcoholic liver disease, or it could be NASH, that is non-alcoholic steatohepatosis. There has to be an SOL in the liver, a space occupying lesion in the liver, and plus the third combination is a high alpha fetoprotein. So if you have these three things, it's a spot diagnosis. Remember that any patient who has chronic liver disease requires a 6-monthly surveillance for ultrasound plus an alpha fetoprotein. Every 6 months you have to do for them, because between these 6 months also there can be an interval lesion, and so it is known as an interval cancer. And remember, everyone, that only hepatitis B vaccination can actually fix this problem. So this is how HPV vaccine and hepatitis B vaccine have changed the landscape of cancer. Now we'll take up all the questions quickly. Well, Dr. Sunday, you said alpha fetoprotein and imaging. Yes, if you have these if you have these two things, it is a spot diagnosis. But we have to stage. The staging has to be based on the tumor size, the number, the vascular invasion, and liver function. So then we have to decide what is the treatment, whether we want to offer local therapy, and local therapy could be local ablative therapy. Can we offer surgical resection? If it is a liver limited disease and not amenable to surgical resection, can we offer liver transplant? If there is any vascular involvement, then they are not candidates for local therapy, and therefore systemic therapy has to be given. And yes, you are right. APRS score decides treatment. So very nicely said. And
Dr. Niti, we missed
yeah,
a question from Dr.
yeah,
Gozi.
I
So
will
the
take that.
Gozi.
I will take that question. So, Dr. Gozi, the question is that you asked me whether HPV vaccine can be given in a patient who's already positive for HPV. Well, the answer is yes, because if you're giving 9-valent vaccine and the patient is positive for one strain of human papillomavirus, still the rest of the 8 strains you will confer protection. So yes, we will offer HPV vaccination to anybody who's even positive on HPV testing. So I will move to the next case now. This is again a common scenario. This was a 55-year-old gentleman, farmer by occupation, and chronic tobacco chewer. It is not only chronic tobacco chewer, but if you have a constant irritation of a tooth, it can happen. So patient had a non-healing ulcer in the right lateral border of tongue of 2 months duration. And there was some pain, but it was not very painful. Otherwise, the patient may have come earlier. And now patient started having difficulty in swallowing because of the tongue pain. This patient would consume tobacco and alcohol. On inspection, there was a 3 into 2 centimeter mass ulcer on the right lateral border of tongue. This was irregular, everted edges with indurated base. And on examination of the neck, there were lymph nodes. So what will be your diagnosis? What is everybody's suggestion? What should I do next? So there's an ulcer on the right lateral border of tongue with irregular everted edges, indurated base, and there's some lymph node. This, yes, I have somebody answering. I'll do biopsy or endoscopy. Yes, I think I'll do both, but yes. So, Dr. Abetu, Dr. Fayera Abetu, absolutely. This is a tongue cancer with cervical mets and a biopsy, Dr. Stefan is recommended. I agree completely. Dr. Ivan, yes. So I think where we are reaching is like at least now we have cancer in control. What we'll do here is that an incisional biopsy was done, and the biopsy was suggestive of moderately differentiated squamous cell carcinoma. A scan was offered after the biopsy report, which showed that there's a 3.2 into 2.1 centimeter lesion in the right lateral border. In the scan, the depth of invasion was 6 millimeter. And of course, the lymph node was positive on FNAC, which was again suggestive of squamous cell carcinoma. So the stage was T2N1, and the patient was offered a surgery, and the surgery was a definitive surgery. And the patient is considered as cured of cancer if the surgery goes well. So what we all need to know about oral cancers are that tell everyone once a month an oral self-examination in front of the mirror, where you are standing in front of the mirror and light on your face. Just one second. I will discuss the recommendation. I'll discuss the recommendation of CLD, but I will finish this first. So oral examination for everybody is strongly recommended, in which you should see your tongue, cheek, the soft palate and the hard palate. I'm sorry. And then, of course, not just that, we should see the tongue, the cheek, the lips, and the inside of the lips, the neck for any lump in the neck. This is mandatory for us to see in our patients, and it's important for patient to do a self-examination. And if there's any lesion which they see is unusual, any red patch, any white patch, any thickened patch known as submucous fibrosis, they should come for clinical attention. So this is about a tongue cancer, which is again a very common cancer in our parts of the country. And I will take Dr. Emmanuel's question next. Are there any specific concern in monitoring CLD, example, frequency of ultrasound and the skill set of the radiographer? It's an extremely good question, Dr. Emmanuel. Well, ultrasound for a CLD patient should be offered 1 in 6 months, and an alpha-fetoprotein should be offered 1 in 6 months. And skill of radiographer is very important, because we all know that this is a subjective test, and ultrasound is a very subjective test, and it depends on the user who's doing it. So if the skill set is not good, then we may get in trouble. But at the same time, if there's any doubt, we should immediately offer a triple phase CT scan or multiplanar MRI or a multiplanar CT scan is recommended. I'll go to my last case, and I'm sorry for stopping in between.
No,
I'm really sorry for
doctor,
the interruptions.
there is some comment. I can't get the name of the doctor because it's the device name that's reflecting. They have written T2N1M.
Yeah,
So,
that is the tongue cancer. That's
okay.
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 So this is our school teacher who's 32-year age, and she has one child. And what she presented was with a very short history. She had easy bruising of the arms, as you can see in the picture. She had this bruising of 2 weeks duration. She had purple patches on her arms. While brushing in the mouth, she had bleeding gums. In the morning, she had gum bleed. She had tiredness and fatigue. She had fatigue and mild breathlessness, which she noticed recently. She was also having occasional headache. And this fatigue was worsening in the past 10 days. There was no epistaxis, hematuria, or GI bleed, and there's no history of any fever or recent infection. And she had not taken any medications like a pain medication or an antiplatelet or an anticoagulant. And that's how she came to us. And these were her findings. She had no family history of a bleeding disorder. She was a non-smoker, never taken any alcohol. She was vegetarian by diet. No history of recent travel to any part of the globe. On examination, she had pallor. She actually appeared fatigued. There was no fever. There were multiple ecchymotic patches on the arms and lower limb. There was gingival bleed and there was a purpuric patch in the cheek as well. There were no lymph node, no hepatosplenomegaly, and a vital showed a mild tachycardia. Other than that, everything was fine. So, Dr. Ivan, throat cancer is a possibility, but why would you have ecchymotic spots in the arms and why will you have gingival bleed, gum bleed for a throat cancer? Any other guesses, please? Yes, I don't know the name from iDevice. Leukemia is one of the possibilities. Any other possibility? I think I'll wait for everybody's answer. Please give me more answers. What do you think? Just drop a message. Thrombocytopenia. Yes, Dr. Gozi, very likely. It could be ITP, immune idiopathic thrombocytopenic purpura. There could be platelet disorder, very much. Any possibility of a clotting function, I mean, coagulation profile being abnormal? Is it possible? Any other suggestion? So I have a young woman of 32 and this is the first time she has come with this fatigue, pale with multiple bleeding spots. And this is a red flag again. What we will do is just a CBC, just a hemoglobin WBC platelet. It could be HIT, it could be gastric cancer, it could be Ludwig's, all are right. Absolutely. I'm very happy with the thought process actually. Everybody is giving me such nice kind of Ludwig's is also a very good possibility. Gastric cancer, yes, but then gastric cancer should not generally present with ecchymotic patches, but yes, possible. Heparin-induced thrombocytopenia is a possibility, yes. So, patient had a CBC, and the CBC suggested a hemoglobin of 8.2. WBC counts were low, 2,800. The platelets were 22,000 on the smear. PT, PTT, INR, all of which was prolonged. The INR was about 2.5. Fibrinogen assay was low, which is suggestive of DIC, and the D dimer was markedly elevated. Peripheral smear was suggestive of numerous promyelocytes with or rods. What is everybody's guess? What is the diagnosis? On this, it's the diagnosis right here, written here. Please tell me. So when you read OR rods, promyelocytes, this is the diagnosis of myeloid leukemia. So the patient had acute promyelocytic leukemia. Promyelocytic has promyelocytes, and OR rods actually are very characteristic of acute myeloid leukemia. Yes, yes, Dr. Davis, Dr. Farah, absolutely spot on. So patient had acute myeloid leukemia, and this is a medical emergency. The woman can die in the first 1 week or the first 1 day as well, because there is prolonged bleeding time, clotting time, prothrombin time, and PTT is high, fibrinogen is low, D dimer is markedly elevated, and patient already has bleeding diastasis. There could be a bleed in the GI, there could be a bleed in the brain, and patient can actually die. So Dr. Gozi, spot on. AML M3 with DIC, that's what patient has. Medical emergency and managed with acute care. What are the red flag signs? Cytopenias. Cytopenias actually point against a clotting factor abnormality. So there's cytopenias, there's coagulopathy. If only you see PTT, APTT being high, we could actually suspect whether patient has hemophilia, von Willebrand disease. But here patient had coagulopathy but cytopenias. And on the peripheral smear, one test which can give us the report is peripheral blood smear. And this patient had promyelocytes. So this is APML unless proven otherwise. Acute promyelocytic leukemia, acute myeloid leukemia unless proven otherwise. These are the characteristic cells. And what do we urgently do is transfuse. We make sure that we have given adequate cryoprecipitates. We have given fresh frozen plasma, which is mandatory to manage the fibrinogen value. Platelets have to be kept more than 50,000 because that's the mandate of an APML. And then, of course, even without having final report, we can give ATRA. ATRA are just tablets. You have to give before we lose the patient. First day, first 48 hours, and first 1 week are crucial and critical. If patient manages this first 1 week, 95% of patients will be cured of the disease and will have very good survival. So first 7 days are critical and crucial to manage them rightly. Thanks, Dr. Ivan. We will have when you tell me. So what did we do? We started ATRA, we corrected the coagulopathy, FFPs, cryoprecipitates, and platelets. Patient required a confirmation for which bone marrow was done and a molecular test was done which confirmed they had PML RARA. So now let me sum up what are the type of cancers globally. Well, when we look at both the genders combined, the most common cancer is lung cancer. So this is one thing which we need to know of. We would have our friends, family, our patients who will be diagnosed with lung cancer. So we should know about lung cancer. The second commonest cancer is breast cancer, even when you put both men and women combined. Then is colon cancer, which we spoke about, prostate cancer, which I did not speak about, and stomach cancer. These are the 5 leading cause of cancers. And when we talk about the death related to cancer, the most leading cause of death related to cancer is lung cancer, colon cancer, and liver cancer. Remember, breast cancer is very curable, so mortality goes down and it becomes 4th in the list. When we look at Africa per se, well, I would suggest this is underreported number. The actual number is much, much higher. This is just tip of the iceberg. What we know is a very small number of patients who are reported and brought to medical attention and actually take treatment. And this is what you and I are sitting here to change. We need to find out who are the patients, wherever possible, treat them and treat them right. This has to be the challenge which all of us have to take, because time is the key. Time is something which can change the dynamics of a person who will survive and who will not survive. The top 3 causes of death in Africa, when we put uh, both gender combined, is breast cancer. Imagine a curable cancer. Patients dying of breast cancer is not acceptable. Second is cervix cancer. Even so you see, women-centric cancer takes the forefront in Africa: breast, cervix, and liver. These are the 3 cancers which have top cancer-related mortality. And when we look at men, prostate cancer has the highest mortality, followed by liver, followed by lung cancer. So over to all of you for asking me anything you want to, or anything you would want to share. And this is what we do. We work together as a team. All of us discuss each and every case, and we deliver what best we can. Thanks so much.
Dr. Niti, I want to, double down on the request by Dr. Ivan, because today's session mostly was focused on common cancers. Maybe we can do blood disorders in another lecture of yours whenever you are happy. I mean, your schedule permits.
And whenever I'm not coughing.
Yeah. Thanks to you. I mean, you could have rescheduled it, but thanks for still showing up despite the illness. And yeah,
Thanks,
Doctor,
thanks, Varun, for inviting me today. Appreciate it.
ma'am,
Actually, everybody was answering. That's so nice.
many of the doctors who participated today, they are requesting your copy of the PPT, ma'am. If you could share that with us, we'll share it across with them along with the participation certificate.
Sure, I'll do that.
Okay. So yeah, ma'am, you covered a liver case. So we also in one of our cases encountered one thing. The gentleman presented with no history of alcohol or the jaundice, and the preliminary test CT triple CT phase staging was not possible. So the opinion here was hepatectomy, resection of liver if possible. And then because of the bile buildup, the gentleman had a crisis and passed away between the during this consultation and visa etc. process. So how could such cases be managed, ma'am? I mean, I know this is limited information for you to go on, but how could such cases be managed? The local doctor managing there.
See, the key is always the right diagnosis at the right time. That's the key for everything. And that's the reason we have come here to discuss what are the things which gives us a red flag sign to find out what we can catch. And remember that liver cancer comes with coagulopathy. So the possibility of them bleeding is very high. The first time, not just cancer, a patient with chronic liver disease, we always have to do PT, PTT, INR. And if there's any bleeding diastasis, we have to treat them. We have to give them vitamin K, and we may have to give them blood products to make sure that they don't bleed. On top of it, a chronic liver disease patient will have WBC low, platelets low. So just basic blood counts, PT, PTT, INR on a regular basis is recommended.
And the last case, ma'am, that you had discussed, which was like sort of a medical emergency, if not brought to attention, that life could have been lost. But those kind of symptoms could be easily go undetected because somebody might feel that I'm just feeling tired, I'm just feeling low, so on and so forth. And okay, the bleeding in the gum could be because I'm brushing too hard. So people may, and the crisis might happen. So how does the medical fraternity or even the patient community, handle
Yeah,
this?
I would suggest for everybody, I mean, all GPs and everybody, one thing I would suggest is just do basic blood test for everybody if there is anything in doubt. You feel that a person is coming with some symptoms which are persistent and you have not explained, always ask for a CBC, which is hemoglobin WBC platelet. Often ask for liver function test and kidney function test. So if we have just these three things, LFT, RFT, CBC, we get quite a few clues. If they are abnormal, we know there's something significant happening in the patient, and therefore at least we become more alert. So just remember to do these three things: CBC, LFT, RFT, and if there's any bleeding diastasis, then do a PT, PTT, INR. Just doing this now, we can save so many tragedies. If you see hemoglobin is low, you have to give attention to it. If you think bilirubin is high, you have to give attention. If kidney functions are deranged, if sodium potassium is deranged. So just instead of jumping into any scans, first a basic blood panel and then take it from there.
Dr. Niti, there is question from Dr. Ivan. So he wants you to, recap the management of leukemia. you discuss that case also.
Dr. Ivan, the basic thing is first we have to confirm what is the type of leukemia. Normally, leukemias are acute and chronic. Acute have short history and they would have low hemoglobin WBC platelets. So, acute will have short history, fever, and bleeding manifestation as the normal presentation. And then there is chronic leukemias. All the leukemias are very common. Chronic leukemias generally happen in older age group. Chronic could be chronic myeloid leukemia or lymphatic leukemia. Acute leukemias could be AML or ALL. So acute lymphoblastic leukemia or acute myeloid leukemia. Now, based on that, we decide treatment. Now the practice is first is to do the genetic testing. All patients should be immediately managed, but in the long run you have to subcategorize them whether they have if is CML, you have to make sure that they have pH positivity or chromosome 922 positivity or BCR-ABL. A CLL patient, we do again fish panel to see what is P53 positive or what is the what are the subdivisions of what are the subcategory. So it's a standard risk CLL or a high risk CLL. Acute leukemias, again, acute myeloid leukemia, also we categorize them as good risk, intermediate risk, or high risk. And based on that, we treat. And acute lymphoblastic leukemia is the most common leukemia in pediatric age group and young adults. So we start with steroids, and then based on whether it is T cell or B cell, we start chemotherapy. When we look at acute myeloid leukemia, we have to decide whether there is M3 type, like this patient is known as acute promyelocytic leukemia, or non-M3 type. So when it is M3 type, which is very rare but very curable, we just give tablets. Tablets are Atra or arsenic trioxide tablet. And if it is AML non-M3 type, then chemotherapy is the recommendation. So this is a broad guideline of how you manage an acute leukemia and a chronic leukemia. Chronic leukemias are often managed with only tablets.
Yeah, there's a comment from Dr. Michelle. Yeah, Dr. Michelle, Dr. Niti has agreed to share the presentation. During the coming few days, Soumya will share it with you along with this certificate, and we will upload this masterclass recording also on YouTube and share it with you.
So thanks so much for today. Thanks, Varun. I think it's sign off.
Ma'am, before we sign off, yeah, we have exceeded the time and thanks. Just one thing, ma'am, just the comfort that you can give to the doctor partners here, because many a times even they would not have clarity because of diagnostic challenges. So when should they? You have pointed out red flags, etc. But when should they? It should trigger that this case.
What I will suggest to every one of you, please write to me if there's anything. WhatsApp me or you please text us for any queries. Quite a few patients can't travel to India. So the intent is that you treat them and you diagnose them on time. Our job is to make sure that patients are safe. So, and they are diagnosed on time. So please ask questions if there's anything. Please write.
So, ma'am, what we recommend to them is like you just prepare a doctor's note with relevant details, and we'll share it with you, and so that if it's clear, you can give the pointers about the management of the case. So, ma'am, you are not also not keeping well. Yeah, thanks for sharing. And we will also share. Dr. Niti has uploaded many educational videos on her YouTube channel, along with when we share certificates. We'll share the link to her YouTube channel also, so that you can access different topics.
Most of them are cancer types which we commonly encounter, and will have details of managing those cancers.
Okay. Thanks a lot. And Dr. Niti, thanks for still conducting the masterclass. It's very obvious you are not feeling well today, but thanks for joining us today. Thank you. Thanks a lot.
Thank you. Thanks so much. Bye.